Hi, good morning, everyone, and thanks for joining the session today. Okay, let's make a quick start. I'm just going to look at placing the code with everyone so that people are able to join. Just give me 1 second. Right. So I've got a few which have joined in. I've got Ashu, I've got Chi, I've got Fatima, Grace. Thanks so much for joining in. I've got a couple more who'd hopefully end up joining. So I'm going to text a few of them just very briefly. Okay, so let's begin with today a new unit. This unit is going to be looking at, talking into a bit of details about person-centered approach. I've got a few documents that I've opened up on my screen, which you don't see as of now, but what I'm going to do is shift you and show you some of the documents as we go along in today's session. So today's session, we are looking at, most of you have covered 2 units with us already. No, all the units in this particular course have to be studied in no particular chronological order. So some of you who are joining new today, which is Abby, Ashu, are looking at starting this as the first unit, and it's one of the core units that you study within the health and social care sector. So person-centered approach, I'm going to start with a bit of a brief introduction about the unit and give you a bit of an overview. And then I'm going to also show you the assignment brief just to put this into a bit of perspective when we discuss and start the unit with a bit of an overview today. And then we will go into the discussions on learning outcome 1. Now, one of the things that we look at in particular when we talk about, what is person-centered approach. So one of the things which normally would come to your mind is that when we talk about health and social care sector, and when we talk about in general providing care to people or patients or anybody who's looking at getting services from health and social care, whether it's a hospital, surgery, community center, pharmacy, any of the settings that you look at, one of the key concepts that we look at is person-centered approach. Now, this unit is going to help you build an understanding on what is the importance of person-centered approach when it was introduced in the National Health Service, and why is it important when we look at providing services. When we say services, I mean by that healthcare services, mental health care services, or any sort of services which are required when people are admitted to hospital or have had a surgery or an operation. So post-operative and services which are required for you to help get back onto your feet would basically all have the person-centered approach in it. Now, just a brief overview that this unit obviously is graded. All the units that you're studying in health and social care qualification are graded. So pass, merit, and distinction, you should be able to achieve a distinction on this unit fairly easily. The reason I say that is, although this is an important unit and there are lots of things that you're going to study, but because the unit size is small, that means it has 3 learning outcomes or 4 learning outcomes with not many assessment criteria. Some of them are easily, achieved, and you should be able to target, either a merit or a distinction grade. Now, we are going to cover this unit in 5 sessions. So sessions on Monday and Tuesday, today and tomorrow will cover learning outcome 1 and 2. Next week, we're going to cover learning outcome 3 and 4. And then the following week, we will do an assignment discussion session to discuss how to put together the evidence for this particular unit so that you're able to submit the assignment. Now, as always, I'm going to provide you some templates. These templates are going to be useful for you to be able to fill in and complete. And once these templates are completed, they will become a part of your assignment, and they would help you, achieve some of these tasks in the unit quite easily. Now, when we look at person-centered approach, I think just to give you a bit of an overview, person-centered approach is, essentially an important part of how, let me just give me 1 second. Okay, so basically, person-centered approach, is an important concept because this was something which was actually introduced by an American psychologist called Carl Rogers, and in the early 1960s. And it was a kind of, an experiment that he did where he emphasized that, there is importance which needs to be given to own experiences and how people go through some of these experiences to be able to provide care in a bespoke or a much more tailored fashion, so that patients, get the benefit of receiving that care when it is being provided by any sort of a facility. And he initially, when he did the experiments, he initially proposed that, care should have certain elements in it. That means elements like empathy, positive aspect or positive regard to what the, patient has to say. You should be looking at, giving independence and some sort of an autonomy to the patient in terms of decision making. And what most carers or people working within this sector need to do is that they need to be able to provide genuine and transparent care, which will be useful for the patient to get back on his feet, or recover from a particular condition, or from a particular trauma or an accident or whatever may that case be. And this approach was introduced into, into the NHS way back in, let's put it this way, in 2008, after Lord Darzai's report. Just trying to recollect the name and got that now. So Lord Darzai's report, and in 2008, this particular bit was then incorporated into the NHS Charter, and it became a part and parcel of how integrated care is then delivered through the National Health Service. Now, there is obviously some bit of reading that you can do, with regards to, and understanding why is this approach quite important, and, how and why and what do we see in terms of a timeline, and with most medical associations endorsing this approach, gradually over a period of time, and then it got incorporated into obviously the NHS and the NHS Constitution. So if we look at certain timelines, this approach and concepts were introduced early in the, into the NHS in the early 2000s. And obviously in 2001, the Department of Health in England established, a committee. That committee actually published a document which was called the Essence of Care and Patient-Focused Benchmarking for Healthcare Practitioners. This document then became, a part and parcel of further reports, which were, obviously generated, and this approach was tested. And then later on in 2008, after this was put forward by Lord Darzai, this particular approach was then incorporated into the National Health Service. Now, in 2012, the Health and Social Care Act was passed, and which made it mandatory as a legal necessity that all staff working within the NHS need to focus on the needs of patient and the goals of patient. And that is where also the person-centered approach actually became, important. Now, we will learn about this approach and this background of this particular approach in a bit more detail in Learning Outcome 1. So I wouldn't want to go into a lot of details right now because I'll be repeating myself when we discuss some of the assessment criteria. But just going forward, as I mentioned earlier, this unit we will cover in 5 sessions. So today we are going to be looking at Learning Outcome 1. Tomorrow, same time, 11 o'clock, Learning Outcome 2. The next week, it will be Learning Outcome 3 and 4. And the subsequent week, we'll do a discussion on the assignment. Now, When we look at teaching and delivering the unit, we just don't teach you any content. The content is also indicated by the awarding organization. So in Learning Outcome 1, we're going to be covering all these details. And one of the things that you will look at is Lord Darzai's report, which comes in, and obviously how this approach of person-centered approach, or how it was invented, how it became important, and what were the origins of this particular aspect is what we will also see by reading on some websites and obviously some handouts, which will be good to get some journal knowledge going about this approach, because this unit, you're going to hear this word or this terminology, person-centered approach, or PCA, a lot many times. So it is good for you to go through some of these details, and they would then help you understand why this has become very important when we look at services being delivered by practitioners, nurses, healthcare workers, assistants, social workers, doctors, consultants, occupational therapists, anybody who works within the sector, and why do they look at all following the person-centered approach. So there are a couple of assessment criteria that we're going to be looking at covering. There are 3 in the past, 1.1, 1.2, and 1.3. And then we will also look at a distinction criteria, which is looking at recommending ways to overcome what are the challenges when you're implementing person-centered approach. Now, if I look at just also briefly, as I mentioned earlier, show you the assignment brief, just to put it into a bit of perspective here. When we look at, starting this unit, this is the assignment brief that we'll be attempting, or most of you will be attempting, towards the end of this unit. And this assignment brief consists of, certain tasks. So learning outcomes that you see in the unit specification turn into tasks, which are in the assignment brief. So there are 4 learning outcomes. You will generally see there'll be 4 tasks which are given in the, assignment brief. Now, there is a bit of a scenario which is given, and this scenario will help us put a bit of foundation or assume a bit of background and foundation in terms of when we start doing some of these tasks, which are directly related to the assessment criteria given in the indicated content. So they're not very different, but the only thing is that they give you a bit of a background to assume, and with that background assumption in mind, you start attempting these tasks. So this is, as you can see, assessment criteria 1.1, 1.2, 1.3, which are 3 bullet points here. And there is only 1 distinction criteria in learning outcome 1, which is labeled as 1D1, and it is exactly worded the same way as you would generally see in the unit specification. Now, if I were asked you to say jump out of the window, you wouldn't probably jump out of the window straight away. But what you'll do is start asking me a lot of questions. That why are you asking me to say jump out of the window? What is the logic? What do I gain from this? So this particular background that you're trying to gain of why I need to do this task, or how will it benefit me, or will I not get hurt, is the background that you normally get in the assignment which is given. Because I can't ask you to just go in and say, can you start explaining what is person-centered values when working within the health and social care sector? So in order to do this task, what I need to give you is a bit of a background, a bit of a scenario, and that would be generally given before you start doing the tasks in the assignment. So this is a scenario for task 1. This is a scenario for task 2. In some cases, some tasks don't have detailed scenario, but because they are going to be leading on to tasks which are coming in from previous tasks, those scenarios will go forward with regards to giving you a bit more understanding in terms of now what is to be done. So if I ask you to make a presentation, you'll say, okay, what kind of a presentation? So I'm going to say, make a presentation on what are the 7 key values of person, what are the 7 values which are covered under person-centered approach. Now you would do a bit of research, you'll come up with these values. These values talk about individuality, rights, choice, privacy, independence, dignity, respect. And then once you've got these values, then in task 2, which I'll say, now that you know the values, can you go ahead and define some of these values and put an example next to it? So you're building on to the assignment as the way, because the way I'm giving you instructions. So similarly, you generally see that these are the things that how it'll unfold, let's put it this way, in the assignment when you go about doing the task. So before the task, there's a bit of an add-on information, scenario, background, whichever way you call it is given. And that helps you understand why this task has to be done or how this task has to be done. And that helps you get the task or you do the task in the assignment right the first time. Now, the Past tasks are very clearly given as bullets in all the tasks that you look at, and all the extension activities would be higher order tasks, which are merit and distinction. So you'll normally see in the assignment brief, or in the, for example, the indicative spec, you have them labeled as 1D1, 1M1, 1D1, 2M1, and things like that. But in the assignment brief, they'll be labeled as what are called extension activities. Now, some of them might not have the distinction criteria at all, or merit criteria at all, and that is where the extension activities might not be listed. Now, the other bit the reason why I'm showing the assignment brief is because when we mark your assignments, I just don't decide that I will mark the assignment this way. There are some guidelines given to us by the awarding body. We look at these guidelines, and these are the things that we look at, seeing in the evidence that you produce. So it's a good way of looking at what would be required to be produced in the assignment, because it will be given as guidelines to us as assessors. And sometimes what we do is, when we provide these assignment briefs, we also make sure that you are having the guidelines to be able to read through, and that helps in some way. Some learners find it very useful because it helps you understand what evidence would the assessor, in this case me, would be looking at when I mark your assignment. So there'll be things like produce an information sheet. So I have a template for that. And then obviously it says describe about a couple of things, and it is going to tell you which criteria these evidences that you provide are going to be hitting. So some of the bits in the assignment brief are also useful for you to go through when we are looking at starting a new unit. And that is what I would recommend you to do so, by giving it about 5 minutes from a point of view of, looking at essentially, let's say, reading it, because this gives you a good background about what the assignment and the unit will consist of. Sometimes awarding bodies will give a template. So as you can see, this is an appendix which is given as a template. And this template basically looks at evaluating your own person-centered values, and what are you good at. And this is a template that we will use to essentially discuss when we talk about the evaluation of person-centered values in your own self. As an individual, you will evaluate these PCA or person-centered values, and that is where it will be useful. So at this moment, just a brief sneak preview into the assignment brief. Nothing in detail that we need to go through, but you need to just have an eye. You need to have a sight on the assignment, so that you have put your eyes through in terms of what the assignment is going to look like. And these are both available up on Moodle. Now, let's start with a bit of a discussion with regards to our first learning outcome that we want to do. And that discussion will be, for that we will switch over to a presentation, and this presentation will cover some of the points that we want to discuss in the assessment criteria in a bit more detail. So let me switch you over to that. Any questions on what I've discussed so far? Any doubts, any questions, anything that you have not understood, please feel free to ask me now. You can unmute your microphones when you're asking questions. You can ask them through the chat route, and then mute your microphones back once you've finished, so that there is no distortion or background noise in the recording. That's great. Okay, I've got 1 or 2 people replying. No, that's fine. Everything is okay. Let's go ahead. Now, what you see on your screen is a PowerPoint presentation. A copy of this is also available up on Moodle, and I will show this to you towards the end of our discussion when we complete learning outcome 1. Now, this first learning outcome that we are looking at is focused on understanding the background about what is person-centered approach, and why is it important when we talk about this from a point of view of the NHS. Now, one of the things that you see on the slide that I put in is primarily an example of how you would go in as a patient, or as a registered patient with a surgery, and you go in and see a nurse or a doctor. So in a few pictures here, what I've done is I've just narrated or tried to show you using a picture, that how patient would essentially go in and discuss a particular problem in person with the nurse or with say your your GP or your general practitioner or your doctor. Now, when we talk about this as a this is a concept, what we are looking at is that sometimes when you go in, you need a bit of privacy. You're discussing something which is private. As you can see, there's a movement of bit of hand gestures by the patient here. So this is the patient, and obviously the lady in the blue apron is essentially the nurse. So as you can see, she's discussing a couple of things in terms of, or maybe explaining a particular situation. And when you look at this as an option, what she's looking at is explaining what is the problem, or maybe we need to put on a thinking hat here and discuss in terms of think that, okay, she's maybe discussing a problem of hers, and the nurse is asking a few questions, and these could be open-ended questions. And once these questions are answered, the nurse then obviously pulls out an additional leaflet or some additional information that she's going to help the patient take away and maybe read through. And this would give you an example of how the nurse would ask open-ended questions. Maybe somebody in health and social care, as a practitioner within health and social care, you'll be open to asking questions. Look at the body gestures, look at the way the nurse actually opens the arms and says, okay, let's discuss. And the idea would be to give that confidence to your patient so that you listen in, you are showing that you're trying to understand the situation, you're willing to understand what the problem is. You are not offering any solutions at this stage until you've completed your full investigation or by asking further questions. And at some stage, what you need to do is when you start showing some details, what then you tend to do is essentially look at, providing additional information through the use of a leaflet. And that would mean that you are, providing information which is factual, providing information which is going to be realistic and accurate, and that would help, let's say the patient understand the situation a bit better. Now, when we look at this as an approach, what we are looking at is we are basically looking at, what is called person-centered care. That means you're going to be providing individualized care, which is focused on what the patient's problem is and not generalizing the situation. So here you're essentially understanding and respecting some of the unique preferences or needs or demands of the patient. And then your focus is primarily on how do I tailor the care which is required, or my advice which is required, or the information which is required to be able to provide that to the patient or the person who has come in and seen. And this essentially shows you the origins of how discussions normally happen with GPs or with nurses when you're visiting a surgery or when you're going to, say, meet a doctor. Now, one of the things that we look at before personalization, before person-centered approach was introduced, the concept of personalization, in health and social care was also being practiced. And this meant that people were provided personalized care wherein they had choice and control over how the care was being planned and delivered. Now, this is essentially something which the NHS already had. And an example, if I have to give you, would be, a common example that I could give you would be to say, sometimes you look at elderly people, and if they are poorly, they would need some help or maybe need some personal help from an assistant to be able to do their daily chores, which could be washing, bathing, feeding, making tea, things like that. So in those cases, what will happen is generally you would see that the council or the community side of the things in health and social care would essentially go in and discuss the requirements with the patient, and then they will make provisions for somebody to be able to visit them regularly. And that person, as a social worker, will be looking at providing certain amount of support and help to be able to do these daily chores for a certain period of time till the patient gets better. And this approach of understanding why do they need a personal assistance to be able to carry out their journal chores is primarily going to be looking at the aspect of personalization. Now, there was a paper which was also introduced and put in, put by the government by putting a committee, and obviously the committee studying it, and they basically came across with a concept called putting people first. Now, putting people first, essentially when we talk about, as a paper, when it came about, led to the planning of how person-centered approach would then be seen to be incorporated into the National Health Service and the NHS Act of 2010. So when we talk about, generally the concept of putting people first, here the idea was personalization. Here the idea was that you would get care which is going to be designed to support your requirements and in a way meet your needs. And the NHS realized, and the government and obviously the Department of Health realized, that there is no one size which fits all. That means I cannot apply the same approach or same way in which I provide care to all the patients. It has to differ. There is no one size which fits all. And that is where this concept of putting people first and personalization actually came in. So when we talk about putting people first and, the theory of this particular theory, which basically evolved, which says putting people first, essentially, came about with the approach of how, personalized care was required to be delivered to patients, because one size fits all doesn't work as far as, is the one size fits all as a concept does not work in health and social care. Now, there is a handout which I will provide. Let me just see if I can pull that handout, putting people first. Let me pull that handout, and this handout that you see is going to be useful to a certain extent for you, because it will give you a bit of a background in terms of reading as far as the reason of why personalization and person-centered approach actually came in. So let me just see if I can pull that out. And so if I show this to you in a second. So this particular approach essentially was, incorporated. If I just briefly show this to you now. And here we go. So this particular approach was incorporated into by CQC as well. And what they did was they looked at this as an approach which will help raise standards in terms of, how care can be delivered to patients within the NHS. And this particular, handout or the consultation which was run, by CQC, then allowed this approach to be incorporated into the NHS. So this is a slightly bigger document for you to read, but gives you the sense of how person-centered approach essentially, was incorporated into, the NHS, and why putting people first came, and personalization. And these are series of steps which basically led to PC approach being incorporated into the NHS. So this particular PDF document will also be available upon Moodle for you to do some additional reading, and this will allow you to essentially, understand the background behind putting people first, and why this white paper essentially, which was published by the government, led to Lord Darzai's report in 2008, and then slowly and gradually led to the incorporation of PCA, as a concept being incorporated into the NHS. Now, when we talk about Lord Darza's report of 2008, when he carried out the review of health and social care reforms as far as the National Health Service is concerned. And when he published that particular report, this particular report was tremendously helpful for the NHS because it helped lay down a new chapter in the history of National Health Service by reviewing a lot of changes which were required to be done in order to ensure that patients essentially receive personalized care when they do need it, in terms when you get injured or when you obviously go through a clinical procedure and things like that. Now, this bit is also something. Now, the report is 180 pages long, but there's a good summary of this report available, which I'm going to also make available, which I would suggest that you need to read. And again, we'll show you why the concept of PCA was essentially incorporated into the NHS. So when we look at the fundamental values of person-centered approach, which is what NHS looks at when they provide services to patient, things like individuality, rights, dignity, choice, privacy, respect, and independence, those are the bits that were recognized that are required, wherein one size does not fit all approach does not work, and that is why PCA as an approach, was then incorporated. So this is a good summary document which primarily provides you the, in about a couple of pages, provides you a summary of, how you would look at, let's say, understanding what is Lord Darza's report and why is it very important as far as, the changes to the NHS approach of how care is being provided to patients was done in 2008. Okay, with this background, what we should do now is go into some of the assessment criteria that we've got to discuss in Learning Outcome 1. Now, the first part, first assessment criteria here talks about, explain the importance of person-centered approach in health and social care sector. Now, it goes without saying that why is person-centered approach important? Because it is important because it focuses on the needs and requirements of the individual. And here, no two individuals that go to see a doctor have the same condition or require the same level of support. So in this case, what tends to happen is that when you go and see your GP, you are going to be meeting your GP to be able to, essentially look at getting bespoke medication or support to help solve your problem or the symptoms that you're having to a particular problem. And that is why the person-centered approach is important. Now, what are the key values of person-centered approach that we need to be able to cover in this particular task? Now, it is easier to say that, when we talk about person-centered approach in health and social care, it is essential, or why this was introduced was it was introduced because we wanted to ensure that tailored care, which is tailored to individual requirements and the specific needs and wants of the individual, needs to be done. Now, these, when I use this term, that it is care which is tailored for specific needs and wants of the individual, this sentence is very important. What does this sentence tell us? What does it tell us that needs to be tailored for specific needs and wants of the individual? So when I say this, I need to be looking at understanding the idea of, what are the needs and wants? And that is where we look at the 7 values of person-centered approach. So the concept of PCA and the quality of care and how it helps in improvement of the quality of care is centered around 7 values that we need to understand as far as this is concerned. So for this, I have a brief template, which I'm going to share with you. And this template would cover task 1.1. Here, we are going to be discussing the 7 key values that are required to be implemented when we talk about person-centered values. And these are individuality, rights, choice, privacy, independence, partnership to a certain extent, and then personalization which is primarily the concept which led to care being tailored to meet requirements of the individuals. So when we talk about individuality, what does this mean? If I now switch you over, so this template I will share with you in a second, but let me switch you back to the slide. So when we talk about individuality, what does individuality mean? Individuality in this case, if I start with, means that we are not going to make any assumptions in terms of what is the requirements that you would have when you are looking at receiving any sort of care from the National Health Service. And this care that is going to be provided to you is going to be looking at and taking into account your preferences. For example, if I'm vegetarian and I'm admitted to the hospital, one of the things which the nurses or the dinner ladies will come in and check with me would be to understand what are my, once they know what are the requirements of food or dietary requirements, they would still come in and check with me that, are you vegetarian? Are you okay? Or do you have any allergies? Are you allergic to any food? Are you okay to eat, meat? Are you vegan? Are you vegetarian? And this is essentially what they are looking at, is by taking into account our preferences on, say, just the meal requirements. And to a certain extent, this highlights individuality. So what happens is, when I have to be given food or I need to have food, and this would be meeting my needs and wants, that I'm a vegetarian, I can't have any fish, meat, or egg. And in those cases, the food which will be served would meet the dietary requirements of protein, carbohydrates, whatever is required, and as prescribed by the doctor, would be meeting my individual requirements. The next thing that we talk about is rights. So I'm going to talk about them in a particular order. And when I talk about the rights, what I mean by that is that, sometimes you hear the term and you say, I have my rights, I know my rights. So here, what we mean by that is that everyone has the right to dignity, respect, and equality. You cannot demean, or you cannot make assumptions or make judgments on an individual. And what you have to do is you have to uphold their rights. And these rights should not be basically, when you uphold, or let's say upheld these rights, then they would help you provide care without any prejudice or any sort of discrimination. And this would help improve patient satisfaction and overall the kind of care or support which is being provided by the setting. Then we talk about choice. When we talk about choice, when we say choice, we mean that we have a choice to make our own decisions. I am going to look at what kind of treatment I'm going to receive, or how am I going to get that treatment, and who are the people who are going to be providing the care once I've had that treatment. So, for example, sometimes if you're diagnosed with, say, for example, cardiovascular disease, for example, which is high cholesterol. Now, there are a couple of options which the doctor can discuss with you, and they would say, okay, because your arteries are blocked, or one of your arteries is 80% blocked, we need to recommend surgery. Now, in this case, the doctor might give you some options to say, should we do an open heart surgery? Should we look at stenting? Should we look at a change of meal, or treat it with medication? And for long-term benefits, look at changing your dietary and meal requirements. Now, these are options that are going to be discussed with you. And then as a patient, you would have the choice to make what is going to be the best option for you. So in this case, when we look at providing options on treatment, you're going to be looking at what kind of care you receive, how you would receive it. You are going to be given the choice to be able to make that particular decision. Now, after that, we also talk about privacy. And privacy, when we talk about, let me put this onto a new slide. And when we talk about privacy, what we are looking at is, in privacy, we are basically looking at discussing, that as an individual, you have certain rights, and your rights to privacy. That means the information which sometimes need to be shared will not be shared unless your permission has been taken, or your family member's permission has been taken. And this would mean that, we are looking at not disclosing sensitive information to somebody like insurance companies or anything outside the NHS, as far as for commercial reasons is concerned. You could also look at privacy in terms of, sometimes we need our own space to be able to change clothes or make a phone call, or maybe behind closed doors when the doctor comes in to do a bit of an inspection or diagnosis. they normally would draw up a curtain. And this is to look at respecting your privacy, to ensure that sensitive information, or you are treated with dignity and respect, and your privacy is not compromised. We also talk about independence. One of the key values under person-centered approach will be independence, and that independence is going to be when you're supporting people to be as independent as possible, which is one of the key pillars of person-centered care. That means here what you're going to do is try and help people build on their confidence, improve their quality of life, which would allow the NHS in particular and the associated organizations to achieve what are called better health outcomes. That means you are basically allowing the individuals to make their own decisions, choose and get the information that they need, and then using that information, looking at being in control by making the decisions themselves. And that is where you're going to respect the individuality of the and independence of the individual, and that is what means by independence. Now we also talk about partnership. NHS, as you know, provides all the services in partnership with a lot of different organizations. So there is public-private partnerships. There are various departments within the NHS, and sometimes when you're undergoing any sort of a treatment, you would need that treatment to be provided by different departments with the NHS. So partnership is very important. So here, sometimes as practitioners, you will develop bonds or closer working relationship or networking with family members of the patient as well. And that will also be termed as partnership, because in some cases you will have to provide information beforehand by taking permission from the patient and then sharing it with their family members to be able to help them better understand what would be the situation or situation like, and in what situations they would need to make a decision. And that is where it will be seen as working in partnership. So here, the person-centered care, or PCC, has a role wherein the healthcare practitioners look at working in tandem with the family members, other members within, or colleagues and other staff members within the hospitals or the NHS, and they look at ensuring that when we look at providing care, there is an active role which patient, their family members, and some of the other colleagues can take part in, which allows them to define and empower them in a way, let's put it this way, which allows them to empower them and obviously build their confidence and gives them the ability to manage their own health and care requirements. And that is where partnership becomes important. A simple example of this would be, if I've had an accident and you had a plaster and you were, say, for example, given assistance through a wheelchair for a couple of weeks, then in this case, maybe you would be, needing assistance to do your daily course. And here is where you see partnership working. So the NHS hospital would discharge, but the community service side of things would then take over. Your local GP surgery will take over, and you would probably get somebody coming in from the local authority as a social worker or as a nurse coming to visit you to regularly change your dressings and check on you. But this shows partnership. So from the hospital to the GP surgery to the community center to social workers, they are going to be working in partnership to be able to help you get back onto your feet as soon as possible. We look at some of the other aspects of dignity and respect, which are part of individuality as one of the values under person-centered approach and person-centered care. So here, most practitioners, anybody who's working within the NHS, is always given trainings to understand that we need to be able to treat patients with dignity, respect, and equality. So here you will take into account, their dignity. That means while they're sleeping, breathing, washing, or changing, you are basically going to give them privacy. And in some cases, you're also going to be looking at listening into them to understand what are their requirements, and those would then you would try and meet them to as close as possible within the boundaries of being acceptable, and they would essentially be looking at respecting their dignity. One such example that I would give you is that when you look at in certain cultures, ladies, when they go in and obviously see the GP or see a nurse, they're accompanied by a male. So in this case, if a check or a scan has to be done, then they would need to make sure that the patient's dignity is maintained. That means if the patient is asked to if a thorough analysis or inspection has to be done, or the doctor has to, for example, feel the heartbeat or look at the chest, then in those cases, proper, measures are taken into place or put into place to be able to ensure that there's a person or a chaperone watching over, and then there is somebody who's supervising it, and then the patient is a patient undergoes some sort of an thorough check, and that is to ensure the dignity of the patient. Respect very closely related to dignity, which basically shows that here, the patient, the individuals that you're dealing with in health and social care, they would be respecting you, your beliefs, your preferences, and your cultural background, so that when they do provide care to you, they are ensuring that they are being careful about not going against some of your beliefs and preferences. And that is where what you do is, a lot of the NHS staff undergoes a lot of training into cultural and diversity. And the reason of why they would want to do so is that you need to be aware of different types of cultures, different types of people, their backgrounds, their beliefs, their religious beliefs. And this allows them, when they come in to get services or care from the NHS, and when you're deputized to provide care or do some work, then you have the appropriate information to deal with the patient in this case in a very dignified and respectful way, thereby respecting their cultural traditions and requirements. And that is where respect also becomes an important part of the person-centered care as a whole. So this, if we explain these 7 values of person-centered care, they would help you understand why is it very important when we look at the reason why PCA was incorporated into the National Service. Is that okay? Any questions on this? Okay, so let's go to the second assessment criteria, which basically talks about how this approach was developed. And as I mentioned to you earlier, while giving you some background on the unit.
Excuse me, sir.
Yeah, go on.
Yeah. So when the assignment is given, and then if they ask you to describe, does it mean that you have to bring the point and then give explanation under it, right?
That is correct, yes. So what you will be doing in this case for task 1, wherein what it basically asks you to do is explain the importance. What we're going to do is look at one particular template, which I had shown earlier, and I'll bring that up again. That template is required to be filled in, and that would help you explain what is person-centered values. And once you fill that template in, that would allow you to complete the task. Because it says explain, so when you do your assignments, there is one part which you'll have to look at is there is a focus on what is called command verbs. Now, there are 3 different types of categories of command verbs. Your past, merit, and distinction command verbs. Generally, in the past criteria, you'll have words which will ask you to explain, define, describe, in general, what is being asked for, and they would be tending to be theoretical. So here, when it says explain the importance, what will that cover is it'll ask you to talk about what are the person-centered values, and you're briefly explaining them in about 20 to 30 words max, and they would cover this particular task. But if it was to say describe, then you would also maybe put in an example in relevant places just to show that you have a good idea and a hold on the concept of a particular person-centered value. So these would need to be looked into when we do our discussion on the assignment brief. And I'll explain a bit more when we come to the end of the unit. Is that okay?
So with a describe, you can still add examples.
Yes, you would be able to add examples to describe. You don't add examples to all places, but what it will requires in 1 or 2 cases wherein it tends to be showing a bit of a practical application. What you're going to do is basically elaborate the definition of the value with maybe a brief example, as I gave in what cases. For example, when we talk about partnerships, it's a big concept. So if I had met with an accident and I had a broken bone, fracture, And then after that, I needed aftercare to be able to get back onto my feet. The example of how social workers, communities, welfare services, the council, the GP surgery would take over once you're discharged from the hospital would be an example of that aspect of partnership being given when you talk about describe. Is that okay? So in describing is basically you're painting a picture with words. And in trying to paint that picture with words, what you're going to do is essentially add an example, because sometimes explaining through an example helps you, define the concept clearly.
Thank you.
Okay, let's go to the second criteria. Now, second criteria is theoretical, and as I would say, it says describe. So here what we're going to do is paint a picture of series of events of how, person-centered approach, was introduced or was developed. So we are going to go into a bit of a history and go into developing a bit of a timeline to say when this approach was started or how this approach came about. So we go back to the beginnings of this, wherein the American psychologist Carl Rogers, in the 1960s, started experimenting with, how care needs to be provided to his patient. And although he did a number of experimentation and he came up with a number of ideas, essentially one of the ideas which he termed as was unconditional positive regard. That means whatever may be the case, you have to regard what the patient's requirement are, by looking at them positively from an aspect, because they would help the patient build confidence and then get better. Now, this approach was further expanded by the American psychiatrist, George Engel. And in the late 1970s, he came up with a particular model wherein he described this term as what Carl Rogers had mentioned as unconditional positive regard. And he basically described this term as what is called person-centered care. Now, his approach was essentially to say that when we look at people having, illnesses, we need to be able to show empathy, understand their point of view, and then put a care plan around it to be able to help them get better. This was further elaborated and taken forward by, the chronic care model, CCM model, which was developed in the US in the early 1990s. And this model essentially was then, further taken forward by, the Institute of Medicine, or IOM, in the US, wherein they coined the term, person-centered approach. Person-centered approach as one of the six aims of the, let's say, care quality plan, which they introduced in the US. Now, obviously, lots of developments started to happen, and obviously this idea at some stage reached, the policymakers in the UK. And while looking at coming out with annual planning for the NHS in 2000, Professor Walnes published a report, which was an annual review report, on the services provided by the National Health Service and the need for personalization. In his report, he focused on the enablement and empowerment of patients, as while providing the care to the, people who are receiving this care within the National Health Service. And later on in 2008, Lord Darzy's report recommended that when we look at benchmarking how people provide services within health and social care, he emphasized on the approach that all people working within the National Health Service need to be benchmarked against certain criteria. And these criteria will need to be created so that when we say that this care is being provided, or this person is doing exceedingly well, or this person is providing great care, but how do we benchmark this? And this particular beginnings of how, care provided leads to a better experience within the National Health Service was recommended by Lord Darzy in his report in 2008. And then subsequently in 2010, this as a concept was incorporated into the NHS Constitution with the NHS Act of 2010. And this particular then thing became what is called a part and parcel of how care or integrated care is provided by the National Health Service to members of public in the UK. So here in the NHS Constitution, it stated that the preferences of patients, their families and carers should be taken into account while the care services are being discharged by health and social care practitioners under the NHS or by the Department of Health. And then after that, what we see is that this approach was then incorporated into the NHS Constitution, the NHS Act of 2010, and today this has become a central core idea in forming policies up for the National Health Service, wherein it focuses primarily on ensuring that anything which is, any service, let's put it this way, which is implemented or recognized within the National Health Service needs to follow the concept and principles of person-centered care. And they were emphasized in the early, policy document in the early 2000s by the NHS and later on by Lord Darzy's report. Now, one of the things which I would say when we look at this as a timeline is that the move towards person-centered care in the NHS is ongoing. It is not that, okay, this has been implemented and this has been done. No. Different NHS trusts which work under, the Department of Health, they are at different stages of incorporating the person-centered care approach within the services that they provide. And when we look at, I don't know how many of you have looked at the national health structure, of NHS in terms how it works. So let me bring that across. So health and social care structure. So let me just bring this across because it is important for you to, because this is an ongoing approach. This is not something which is a done deal or has been incorporated and that's been done. No, there are different trusts which work on different things, and at different stages they are in different stages of how the growth. Say for example, this care is being incorporated as far as the health and social care sector is concerned. So let me bring this across as a chart into our discussion. So this would, so if you look at this as a, as a structure for the National Health Service, what we do get to see here is that, obviously, let me see if I can bring something across which is more like a, yeah, this would be much better. I think this is slightly better because what we want to be able to look at is an overview. So if you look at the, the NHS in particular, you have the UK Parliament, you have the Department of Health, the Secretary of Health currently. Do you know who's the Secretary of Health? Who's the Secretary of Health currently? Any idea? Steve Barclay. So Steve Barclay is the Secretary of Health. He leads the Department of Health and Social Care in England. Essentially because there are 4 devolved governments, so you have somebody else as a person taking care of that in Scotland, Wales, and Northern Ireland. Now, the Department of Health basically runs the NHS England. There is funding which comes from the Department of Health, and obviously then it goes on to the local authorities. But the NHS England is actually a combination or working combination of what are called the clinical commissioning groups or CCGs, and there are 211 of them. Now, under the CCGs, you have the NHS. It reports into the NHS trusts, the NHS Foundation, and you also have certain external regulators and agencies which basically monitor how these services are being provided to the members of public. So one such key regulator in the sector is, Care Quality Commission, CQC. There are other bodies like NIC, National Institute of Care and Excellence. You have the King's Fund. You have MIHR, which is the Medication Authority. Approval of medications and everything happens. MHRA, which is Medicine and Health Regulatory Authority. There are lots of these other bodies which are semi-government and autonomous bodies which basically look at maintaining, upholding, ensuring that policies, processes, quality of care is being delivered, when services are being provided by the National Health Service. Now, under the CCGs and the CCGs typically would have hospitals and trusts. Under hospitals and trusts, you'll have basic care, which will be primarily provided to GP surgeries, dentists, pharmacies, opticians, and then you have the local authorities supporting this through the structure of, health and social care workers and additional support, which is given through the community setup in various locations. Now, this is the overall structure. This structure now if I have to expand this, goes into by giving examples. So the Secretary of State and the Department of Health creates policies, regulation, legislation from the Parliament. Then this is funneled down into what is called regulatory authorities, the MHRA, Medicines and Healthcare Product Regulatory Agency. You have the National Institute of Care and Excellence, Health Research Authority, the CQC, and Monitor, or PHE, Public Health England, as we call it. They monitor these activities, localize them, and then provide them to the National Health Service so that they can be incorporated as what are called legislation is then converted into acts, and legislation are converted into policies and procedures, which can then be adopted within the day-to-day working of the National Health Service. So these organizations are regulatory. Then you have national level organizations like NHS Trust, Health and Social Care Information Center, the NHS Authority, the Clinical Commissioning Boards, the Health Watch England, NHS litigation, and NIHR, National Institute of Health Records and Research, Public Health England. These are bodies which basically are at the national level, which form policies. Then once these policies at the national level are formed, because in certain places there are devolved governments, then these policies are taken on by local organizations or local governments, local authorities, to be able to form into policies and procedures, which then can be implemented within a particular city, town, or a borough. Now, if you look at London, there's a devolved authority, Greater London Authority. You look at Manchester, GMCA, Greater Manchester Combined Authority. You look at Merseyside, you look at Northeast. A lot of these councils, which are local government bodies, have got devolved powers. So implementation of and adaptation of policy at the local level of how it will best serve the members of public in a local area. So in Manchester, how it will best serve how this policy would be best serving the members of public in the Manchester area, this decision is going to be taken by the GMCA. And then within the GMCA, they will get funding policies. And once they get that, they will then provide it to the front tier level organizations, which will deliver these services to the patient. So hospitals, care homes, old age home, dentists, GP surgeries, public health services, community health services, mental health care services, they are going to be provided by these frontline organizations, which are going to deal with patients and members of public directly. So when we look at this particular structure of health and social care, the implementation of person-centered approach might still be happening in certain, because it was adopted in 2010, depending on how big the authority is or how big the PCC trust is, how many hospitals it manages, how many surgeries it manages. It might be still an ongoing process, which is what I wanted to emphasize when I wanted to show this structure of Department of Health. So this structure of Department of Health, is still in some phases implementing the person-centered approach, depending on the area or the local government involved in terms of number of population. For example, England, if you look at 57 million people, there are maximum number of PCC trusts, PCCT trusts, are based in England, and they would be responsible for essentially providing this localization of what is called the person-centered approach and incorporation of this in the facilities and usage of it on a day-to-day basis. So this is the history or a timeline that we need to understand when we look at describing how this approach was developed. So it started in 1960s from Carl Rogers, George Engel. Then we went into the Institute of Medicine adopting it, the Van List report in the UK in the early 2000s, Lord Darzai's report, and then finally the Department of Health and the Health and Social Care Act in 2012, incorporating person-centered care bases the person-centered values as an integral part of how services are going to be provided within and by the National Health Service, leads to the creation of what is called the person-centered approach in the NHS. Is that okay? Any questions on this so far?
Yeah.
Yes, any questions? Okay. Let's go to the third assessment criteria, which talks about what are the challenges which are associated with, person-centered approach. Now, we know it's all great. I need to respect, I need to take into account dignity, I need to look at individuality, I need to look at respect, I need to look at partnerships, I need to look at choice. All that is great, but how do we look at sometimes, when we are implementing person-centered approach, how do we see and ensure that sometimes when we are faced with hurdles or problems, how do we overcome these challenges? One, first to identify what are the challenges. And then once we know the challenges, how do we overcome these challenges to ensure that we are still delivering and providing care using the person-centered values, which are important within the NHS. Now, what are the challenges that you could face typically when you're dealing with patients? Can you think of any challenges that come across when you're dealing with patients?
Yes, I think especially when they can't talk back.
So one of the things could be communication. If I broadly generalize it, communication sometimes can be, it could be if they speak a different language, they maybe come from a different cultural background, or sometimes their interpretation of what you're explaining might not make sense to them. You're explaining something, but they are also, on the other hand, getting it as a different, they see differently, and that would be posing a bit of a challenge. That's a good point. So what else can we think of? What could be the other challenges that we face sometimes when we are looking at this approach?
Another thing is mobility. Maybe some of them can be on wheelchair and they cannot easily move around except they are being supported.
Correct. So some of the challenges that we need to look at when we talk about individuality, respect, and obviously their dignity, it could be that they are, let's say, physically placed in such a situation that it does not allow us to fully implement some of these values while delivering care. For example, they might be a bit, let's say, strong-headed or be more self-reliant, wherein they would not allow you to push the wheelchair or, allow you to do certain parts of the aspect which they would want to do it themselves. And in those cases, sometimes disability, which the individual might have, could also pose a challenge because they see you as an outsider. They don't see you, they don't trust you or have confidence on you yet, wherein it could become a bit of a challenge. Some of the other challenges that we can also think of is when we talk about attitudes, when we talk about, their culture, where people come from, what is their background. And in some cases, we also look at they could be challenged because of the fact that they do not have family support, or they do not enjoy the support of their family. And in those cases, the entire aspect of providing care depends on or falls back onto the health and social care workers. So broadly speaking, you would see challenges which could be faced when we see them in various situations. And I think one of the right ways that to think of what could be the challenges is to think of situations like you thought about disability, like an example, a wheelchair, or in some cases, you mentioned attitude, and they would give us good idea in terms of what could be the challenges. But broadly, if we look at those situations and identify and group them into clear heads, the challenges would be communication, their cultural background. It could be related to, their support system, and it could be related to their beliefs, values, and preferences. Now, when we look at these challenges, which generally come across when you're trying to provide care to the patient, how do we overcome these challenges? One of the things that you will see is that when we look at challenges is in the health and social care sector, there is a lot of emphasis placed on training and development. And the reason why there is a lot of emphasis placed on training and development is that if you understand culture, the way people, say, for example, from where people come from, what are their beliefs, values, and preferences, then it'll help alleviate a lot of pressure off, the health and social care staff, is because they understand the culture, they understand the values, they understand their beliefs, and they respect. And then because of the information that you have, you're able to then respect their values, cultures, and belief, and the way they're looking at reacting or coming from. It will help you develop a partnership or a bond with the patient quite quickly. So the emphasis on training and development tends to be one of the key aspects of how you would overcome this challenge. The second aspect that we look at is a lot of us have to do mandatory trainings throughout the year, and some of these trainings carry a communication aspect of it. So, for example, there's a new equipment being introduced, or for example, a new process being introduced in the organization, or a new policy being implemented in the organization in terms of how the care would be delivered or how you would deal with the patient. And if you understand these, it will help you understand and implement some of these policies and procedures when you're dealing with patients much more effectively. And that is where trainings are done primarily, or people are encouraged to attend trainings and be a part of small groups to be able to put some of the learnings that you've got from trainings into practice, and that would help help, I would say, build a bond with the patients, thereby reducing a challenge in terms of maybe attitude and communication, because you are very familiar with the patient, or you are able to break the ice with the patient because you know their culture, their background, and you have information about it. And that practical side of training, helps overcome these challenges. One of the key things that you will note is that when nurses, or when you're training as a nurse or a healthcare worker, you're put into a training essentially, and that's a practical training. That means you're attached to a hospital, a care home, or some sort of a let's say a setup wherein you will go and work. You'll closely work with somebody who's an experienced staff, and you would essentially be following their lead in terms of picking up some of the best practices, and that would be done through practical training. And that is why it is important to put people working within the sector through some sort of an on-job training or practical training, and that allows them to overcome some of these attitudes or problems related to communication. We will also see that sometimes there are creation of new roles. If there is a problem which has been faced for the first time, like during COVID-19, nobody was aware of the pandemic, and obviously newer measures were introduced, new roles were created. And why these were created was that there were people or staff who were able to adapt and come up, let's say, with let's put it this way: they were able to essentially understand that what are the challenges in dealing with patients who are coming with COVID virus as symptoms, and those who were able to understand this much better than some of their other colleagues meant that they were asked to step into a role, and this new role that they stepped into allowed them to act as what are called mentors or coaches, to be able to train some of their own staffs and colleagues in relation to dealing with the COVID pandemic in a much better, in a much quicker way. So when we talk about challenges, we need to think about situations where you would generally see that you would be challenged, or you would be facing a hurdle, or let's say an objection from the patient. And this could be solved by looking at effective communication. This could be solved by looking at training staff, or allowing them to do practical training under supervision, to be able to gain or learn the best practices, or as we say, tricks of the trade quite quickly. There would be focus on reading, and obviously looking at historical perspective in terms of how this was treated, or how people would how somebody else dealt with it. And again, that is the option wherein we look at the perspective of people going through some of the existing situations which have happened in the past, and that allows them to quickly learn and get information related to why this has happened, or how this has happened, and how this was resolved. And one last thing which I would also mention is that sometimes when you look at trainings, there is a lot of trainings and focus on trainings within the National Health Service from a point of view of team related trainings, coordination, building coordination between different teams. And this is an important aspect in terms of understanding that where your work starts and where it ends. And when you hand over, we've seen the concept of handover when the shifts change within hospitals, when you work, or when you work as a nurse, or as a doctor, or as a as a healthcare practitioner. When your shifts change, there's a proper taking over happens, so that you're basically making the person coming in taking up the role for the next shift You make them aware of what is happening, how is it happening, how you've dealt with the situation. And that debrief that you do in the handover allows better coordination to happen. And that leads to also helping to overcome challenges. Sometimes you will see, just an example, if I was a nurse and I was handing over, now my shift is finishing at 12 o'clock and I was handing over to my colleague, what I would then do at some stage would be essentially tell the nurse that, okay, this patient requires this thing. His medication is very important. He's a bit, fidgety, or he's a bit more demanding. And you would basically ensure that these are things which are provided in your handover to your colleague, so that her job or his job becomes easier when they start their shift and they know that this patient is a bit more demanding, or has specific requirements with regards to his care which is being delivered. And in those cases, coordination between teams is also very important to help overcome challenges. Is that okay? Any questions on this so far? Right, that brings us across to the last assessment criteria, which is a distinction criteria, which focuses on understanding what are the ways through which we can overcome challenges. So this bit that we discussed in terms of challenges itself, and then some of the bits that we look at how to overcome these challenges, is what we have to look at recommendations here. So if I put it this way, that we need to look at some bits of recommendation that we need to be able to make on how do we overcome some of the challenges when we are faced with in terms of providing care to the patient. So here, when we look at these challenges, what we need to be able to do is think of a situation. And when you think of a situation, this situation would help you understand what would be the ways in which you would look at overcoming this challenge. So for example, what I've done is I've looked at the current practice before person-centered approach was introduced, and it was personalization or putting people first. And now the approach, which is person-centered care, and then see what is the difference between the two, and how does it help us come up with, say, a particular way to come up with and overcome that challenge. So if I have to give you, say, one example, which we discussed in the last criteria, was training, adequate training. Now, if I was to, if there was a new X-ray machine being installed within the hospital, and I was working as a radiographer or as one of the persons responsible primarily to bring patients in to get a scan and then obviously take them back to their ward, one of the things that I would need is adequate training. Now, if I give adequate training, which is in terms of how the patient needs to be prepared, how early the patient needs to be brought across to the X-ray scanning center, what are the precautions, what kind of clothing they need to wear. If I'm aware and if I'm given this adequate training beforehand, then my way of processing and helping the patients to go through this scan would be quicker, easier, and much more effective. And such trainings would help me understand what are the patient's perspective. For example, if there is a wait time of 20 minutes, then I'd ensure that they are wearing appropriate clothing. If it's not too cold, then we need to ensure that they have blanket or some sort of sheets available with them to be able to avoid being too cold before the scan is to be done. And this training would allow me to overcome that challenge. One, the patient would not ask me too many questions. They would feel much more relaxed, and this would allow the process of the scan to go very smoothly. You can also look at, I would put it this way, at a senior level. Well, we have been talking about a lot of practical examples, but if I look at policy level, if I look at the hospital, at the senior management level, leadership and sometimes embracing change requires, could be challenging. So here, what I would say is sometimes strong leadership is required to help drive that change, or ensure that staff is showing the correct behavior in terms of communicating to the patient and understanding the importance of some of the policies being implemented within the organization. And that would be a challenge which leadership would need to overcome, and that would be overcome through consistently applying the communication techniques, or using the right communication techniques to be able to brief the staff when you start a shift, or for example, if there is memo being released by the leadership of the hospital to say these are the figures for this month, we need to improve these, they would be useful for overcoming challenges. One of the biggest challenge, I think none of you mentioned, I should have mentioned earlier, comes to be from time management. You are working through your shift, you are a nurse which has to give medication to maybe 20 patients. And if one patient, two patients tend to ask you too many questions, you are spending too much time on it, and that does not allow you to complete the round that you're doing in terms of delivering medication to all the patients. So time management tends to be one of the biggest challenges which I've seen practically within hospitals with nurses, healthcare practitioners in particular, that when they go in, you're not, the patients ask you too many questions, which means you're not able to allocate sufficient time for patient consultations or their queries. And this can be sometimes quite, resource heavy, because they might ask you lots of questions wherein you do not have answers for these. And then what tends to happen is you spend a lot of time with the patient explaining things, and that leads to unnecessary delays and obviously issues with patients. So one of the clear challenges that we could look at, which we need to overcome by applying person-centered approaches, overcome time management challenge. And when you see that, a practical example that I normally would give you is when you speak to a doctor at your GP surgery, you go with a set of problems, you get an appointment. And then when you tell him that, okay, I want to also find out about my, bloods or my diabetes or my sugar, they say, okay, no, I've only got 10 minutes for you. I don't think I'll be able to deal with you in this particular query. You might need to take another appointment. And this shows you an aspect of how time management tends to be a challenge. And in order to overcome this, what we have to do is the doctors and the GPs clearly specify that I can deal with you, or I can give you time to deal with you for one problem that you have, one query that you have, rather than two queries, because I've only got 10 minutes to deal with you as a patient when the appointment is taken in. For any other query or question that you have, you might need to, or issue that you might have, you might need to take a separate appointment. So these are things that you'll have to think of when we need to discuss about, ways in terms of how we can overcome challenges. And one of the key trainings that nurses, healthcare practitioners undergo within the NHS is they undergo time management training to ensure that they are able to give sufficient time to patients. And this time management training allows you to overcome the challenge which is associated with, person-centered approach. Is that okay? Any questions on today's session so far? So this helps us cover learning outcome 1 in a lot of detail. Any questions? Any questions, anybody?
Okay, this is just by the way, I think we are not there yet. As you said, one of the challenges is the time management. So if you are with a patient and then you need to attend to most of them, but one person has stuck you, asking you a lot of questions. In this case, what will you do?
So in this case, what we will do is basically, when you see a situation like this, you will basically look at breaking it down into 2-3 aspects. One is, if you're being given a responsibility to do and provide medication, for example, and your main role is that you have to give medication in your rounds in the morning, you have to go and ensure that medication to all the patients is given. You would basically politely mention to the patient to say, okay, I am responsible for delivering medication to all the patients, and I might not be able to answer this query, but I will pass your query on to the clinical nurse or the registrar or the doctor which is on rounds, and they will come and address this particular query, because I do not have, for example, the answers to this. So you'll be upfront, you'll be frank, and you'll be transparent in terms of saying and acknowledging that this is not your role. And what you would be able to do is basically have somebody else come to the patient to discuss this, who is authorized to discuss and would be able to give a suitable answer. And that is what I would suggest you would need to do.
Okay, thank you.
Okay. Because sometimes what tends to happen is you ask, a patient starts asking, and then their family members start asking a lot of questions. And although you don't want to be rude, but you have to at some stage emphasize that this is outside
And
my
then you'll be summoned.
responsibility. I've got I've got this job to do. And what I can do is I can come back to you after, once I've administered medicine or I've had my rounds, or, you know, I'll ask one of my colleagues to come in and address it. And you have to be polite and upfront to be able to say this. And in most cases, patients understand. If they don't, then you can always fall back and say, okay, I'll ask one of my managers to come in and speak to you, because they would be able to answer this question better than you ask, better than what I can address. Is that okay?
Yeah, thank you.
Good stuff. So just very briefly looking at, you know, what you're going to be seeing on Moodle when you log into Moodle platform straight away. What I want to do is show this to you here. So this particular unit, person-centered approach that we are reading right now, that's the presentation that I've gone through, which is learning outcome 1. And that's the presentation that we have gone through today in terms of our discussion. Now, one of the other things that you will note is that Lord Darzai's report, I will move it up so that you can read it under the learning outcome 1 itself. That's the summary of the report, which I showed earlier. That is a good read to understand how PC as an approach was incorporated into the NHS. Now, the other handout which I've added here is what is person-centered approach from Healthcare Foundation. So what we've discussed, and you see some parts of the beginnings of how this was approach introduced by Carl Rogers. The history, the background, the timeline is very beautifully defined and, you know, covered in this particular handout, which is about maybe give or take 13, 14 pages, minus the branding and other bits, but it's a good read that I would suggest you to read it for understanding learning outcome 1. And then the Word document, which I've uploaded here, which is the document that I've shown you earlier, which is person-centered values. If you go ahead and actually complete this Word document, that would help you achieve task 1.1. And this is the Word document, which I'm showing you now. So you will be able to download it and fill it in, press enter. Obviously, the font size I've made it is, you can reduce it to 12, and that would allow you to fill the details in, you know, in the document. Just keep pressing enter if you need to expand. And that would essentially help you cover task 1.1. So this bit, which is the document that I've shown you, needs to be completed so that you are also completing tasks as we go along reading this particular unit. Then there's a handout specifically for challenges 1.3. And this is a handout which has been extracted from how person-centered planning or person-centered care approach is basically put into place. And as you would see, it will describe what we have covered and identify challenges and how do you overcome these challenges, which is given in this 4-page handout, which I would suggest that you need to you know, read. And then last but not the least, for distinction handout, I put in, you know, a good article or an article published by Health Foundation, and it talks about, you know, how do we look at overcoming challenges and what are the ways through which recommendations the Healthcare Foundation makes. So this particular chart is something which I've taken from here in the presentation slide, and will give you more information about recommendations of how to overcome these challenges when you're facing them. So that bit, I would suggest that you need to go through on your side, you know, after the session, maybe today or later tomorrow, after covering learning outcome 2, and they would help you crystallize what we've covered today and, you know, help you understand in a bit more detail of what we have covered today in the learning outcome 1. Okay.
Okay, so please, with the 1.1, the person-centered value in practice, should we fill it in?
Yes, you have to fill it in and have it ready.
And where do we submit it, please?
You will need to submit it after we have completed the unit, but fill it and keep it at your end. Towards the end, when you do the discussion on the assignment, then I will discuss that, okay, this part you have covered, you need to, you know, elaborate and, you know, obviously combine it with the other part of the tasks that you do for the unit, and then submit it as one assignment.
Okay. Okay.
So thank you so much for attending today, and I'll catch up with you 11 o'clock tomorrow, same time, to discuss Learning Outcome 2. All of you are in the WhatsApp group, so please make sure that you're able to essentially join in on time. And today's session was slightly longer because we had a bit of an introduction of the unit, but generally most learning outcomes will be 45 minutes to an hour, and hopefully you will be able to join us tomorrow as well.
Sorry, can I just ask a question, please?
Yes, go ahead.
I don't have access to the model.
Don't